want to thank you all for coming back in and being ready to participate in this. We're going to start off with a couple general questions that have been asked. So first of all, is there a social network or Facebook group for culinary medicine professionals? At this time, Health Meets Food does not have that, but we do have a LinkedIn page. So it's more on the business professional or the business social media aspect. So feel free to find us on LinkedIn and certainly start following, and you can interact with many of us that are also on LinkedIn for that. So that would be your go-to for that. And then I believe Dr. McDonald said either earlier the Flavor Bible, was that correct?
Yeah, the Flavor Bible.
Flavor Bible. So that was a question about the reference that we wanted to know to help investigate on those flavors in terms of that. So I thought I'd like to open a question for both of you to kind of address with that. And we talked about a little bit earlier with after the skills aspect, but when people are not confident in their skills in the kitchen, like when you're interacting with those, whether it could be even in the food service area where they're just used to just warming and serving in terms of that, or obviously our patients, how do you help them build those skills, and what ways or what techniques have you both found successful to help guide them?
Okay, you want to start?
I mean, I think from the perspective of folks working in institutional kitchens, so back to this idea of school lunch staff members, it's definitely one of those things that if you went around the United States and asked folks in school kitchens how much training they've received in their 20, 30 years doing this job, a lot of them would say zero, or very minimal. There's a certain amount of training that they need to receive as part of the National School Lunch Program. It's like a USDA mandate, but it's like 10 hours, and it's usually about school lunch compliance and things like that. So my answer is very simple. It's training. It's actual training. Like, training takes time, it costs money, that's why it doesn't happen. But it's very difficult to expect somebody to prepare food from scratch or prepare food in any sort, even to heat something up properly, safely, requires training. And I think most people out there who have no exposure to the food service space would be shocked by how many people work in food service who don't understand very basic concepts. And this is not taking away from these folks at all. Particularly food safety, like how many people send their kids to camp where food's being cooked by like another teenager who has no idea what's going on. I mean, it's the truth though, like it's crazy how people have not received training. So a very simple, basic answer, and it's not some clever answer because obviously this takes time and money, and in particularly in institutional food spaces, there is not a lot of time and money, particularly money. But I think there's really no way around in those spaces to not give people hands-on, consistent hands-on training. So that's my answer to that.
Yeah, I agree with everything you said. So training, hands down, is important. I think it's one thing to be confident, it's one thing to be skilled and trained. In my clinical setting, so if I'm in clinic with a patient, I try to use motivational interviewing, okay? And with motivational interviewing, I really take the role of just asking a lot of questions and helping people navigate their lack of confidence. So when they're, even if they say they're not confident, my role is to really probe, like, well, what do you mean about that? What are you not confident? Or what aspect of cooking is intimidating? Is it the time? Is it the preparation? Is it not knowing, recipes, not knowing techniques? So I really try to hone in on exactly where the confidence gap is. And once I really understand what the problem is, it makes it a little bit easier to navigate because now we have the details. So like he said in his talk, what do you mean by good? What do you mean by bad? There's a lot of terms that we use to communicate that don't really have a whole lot of meaning. There's a lot of fluff. So I try to get past the fluff and get to, the actual detail. And even, it's the same techniques that I use as a physician in general. Like somebody will come into my clinic and they're like, yeah, something's wrong with my stomach. I'm like, okay, well, like, what do you mean by that? Like, I don't know what that means. I don't feel confident in the kitchen. Like, what do you mean by that? Like, do you have low self-esteem in the kitchen? Like, when you walk in the kitchen, all of a sudden you feel bad about it? Like, what what are we dealing with, you know? And then once we get on the same page, then I can help navigate. So if it's a matter of, well, you just, don't feel comfortable cooking because you never learn anything about cooking. So there's resources that we can provide, some of which are free, so our free cooking classes. But again, just because they're free cooking classes, sometimes people don't have transportation to cooking classes. There's a bunch of online resources. So, there's probably too many online resources nowadays. So we really have to help people navigate the good and the bad and ugly on YouTube and Instagram and TikTok. And I do think there's probably should be more of an effort to even like judge and educate people. Well, how do you rate these online, programs that we see? One program that I do like that's online is not only the culinary medicine program, but also Ruby. So Ruby, Rouxbe. They have an online cooking school, and they also have modules for patients. And I think those modules are pretty, relatively affordable. And even as a physician, if you contact them, you can get some free access for patients. So I think every month they give me like access for like 100 patients or so.
Excellent. Thank you for that. So this one was addressed to one of you, but I think I'd like to hear both of your answers in terms of that. And it relates to the emotional attachment with food in terms of especially eating our favorite foods. And it kind of gets into that readiness to change question too. And we see this, the school sessions, right? In school settings where kids have their favorite food, pizza on Friday, pizza on Monday, pizza on Wednesday. Those types of things, perhaps, and then also the patients having his hot dog every day, right? So he probably must have liked hot dogs a lot, so it's definitely a favorite food for him. So how do we help understand where that's at for the patient, and how can we kind of gently nudge them off that favorite food attachment?
I mean, one. I don't like talking about good and bad food, first and foremost. So when people say they like, pizza, they like hot dogs or whatever, like the reality is these foods are amazing, okay? Like pizza is freaking amazing. And a Chicago-style hot dog is delicious. I'm a Chicagoan, so like I get it. And I don't want to say, well, this is bad, okay? So, I've had people come in and they'll tell me, like they ate peach cobbler the other day. Now, peach cobbler, it's not necessarily quote unquote the healthiest thing as far as if your goal is to lose weight, but that's just it's a one-off dish. But if me as a physician were to say like, well, that's bad for you. Now, I want to take a step back. If that peach cobbler recipe was like their grandmother's recipe, and it's what they made every, Thanksgiving, every Christmas dinner, and, their grandmother has passed on, but this recipe still represents their memory, and here I am as some physician coming out of nowhere saying this is bad, that's very disrespectful and very offensive. So I'm very careful with the language that I use when it comes to food, and I really try to get to the details. I mentioned the health belief model. So more or less, when people have their favorite foods, in order to connect with the patient, I ask them like, well, what do you like about this food? So what is it about pizza that gets you going? And when people start getting excited and they start sharing what they love about food, it opens the door for further conversation about other possibilities when it comes to food. But I start by really trying to connect with what they love. So instead of trying to, discourage people from doing what they love, I use that as a tool to actually connect with them. And then I can talk about tweaks. And even if it's something like pizza, like, okay, well, maybe we can make pizza a little healthier, okay? Mm-hmm. So let's add some vegetables on top. Let's make some tweaks. And even with his hot dogs, okay, well, let's try to figure out what do you like about hot dogs? And if it's like, well, I really like the relish, like, okay, we can make a slaw. Like we could do something with that. We can get rid of the bread and make, some bowls with some sausage. And that may not necessarily be, the lowest sodium out there, but it is sodium dish out there. But it's a step in the right direction. It's a step towards, showing people how to kind of move away from some of the ultra-processed foods and really embrace cooking at the end of the day.
Yeah, it's a little different. I know a different situation, but I know like in schools, if we go into a district and they have a menu and we want them to maybe ideally, and honestly, one thing I didn't mention up here is we never go into school districts and tell them what they should serve or not serve. We're really saying, what do you want to do? What direction do you want to go with your menu? And we're going to help you get there. So if the director is like, oh, you know, we want to move away from serving pizza every day or whatever it may be, and again, pizza is delicious, and I would question anyone who says otherwise, you know, to be honest. So it's unrealistic to go into a district and be like, okay, you're just going to take pizza off. So like our approach usually is there something that, you know, if we can put something on the menu that kids are really going to like, that is more in line with the goals of the program. So, you know, maybe it's a scratch-made meal or whatever it may be, that could take kids, you know, I don't want to say distract them, but make them happy. Could suffice this like gap now. Like the idea of going into a district and taking things off the menu without replacing them with things that kids really enjoy. For us, that just, it doesn't work. So it's very challenging. So for us, we have to take it pretty incrementally in terms of finding replacements that kids will enjoy. And obviously pizza is a hard thing to beat. But, you know, as he was saying, like, are there alternatives to maybe that particular pizza? Maybe. So I think for us, in the way I think about it is like, even in my own life, it's kind of like if there's something I really like to eat and I'm going to stop eating it, it's like, what's going to take the place of that? Is there something that I'm going to be happy with? And with the kids, that's what we're always seeking for. And sometimes we figure it out and sometimes we don't. And obviously that doesn't stop us from making some moves with the menu, but I would say it goes much smoother with menu changes when you have something just where kids are like, wow, okay, I'm excited about that. So I don't care that we're not getting, but I also think it's in reason. So it's not like, hey, you serve pizza 5 days a week on a school lunch menu. You don't go to 1 day a week overnight. You go to 3 days a week, and you have on one of those fourth days, you have something really good. And I think it's all about, you mentioned Pizza Friday. When we first started doing this, I was like, ugh, I hate the idea of Pizza Friday. But like, I don't know, kids love the idea of Pizza Friday, so just do it. Like, just lean into it, you know? And I think you could take advantage of excitement. I think the idea of like finding where people are, you know, where whoever you're feeding or whoever's feeding themselves is excited about food, if you can harness that as best as possible, it's always a great thing.
Yeah, and I really like using that health belief model. So, you know, in the case of pizza or hot dogs, the health belief model looks at perceived benefits, perceived risk, perceived obstacles, and motivation. So if I'm having a conversation with somebody, you know, first and foremost, it's like, well, what is your overall goal? Like, is your goal to, you know, decrease your blood pressure and come off medications? Is your goal to prevent your risk of developing blood pressure or decrease the risk of developing blood pressure? So as long as we have an understanding on what their motivations are, from there, I can go through, well, okay, so you're doing hot dogs every day, you're doing pizza every day. You know, what do you think the benefits are of that? Or like, what are you getting out of this? And they can talk about their joy and, you know, they love pizza and everything. And then I can go back, well, like, so what do you think about this impacting your goals, you know, to have a lower blood pressure? Like, what do you think? So instead of me giving the answers, we're kind of having a conversation and they start coming up with solutions based upon my prompting. So it's not only a combination of it's not only using the health belief model, but also using motivational interviewing simultaneously. And I think with that, it takes a lot of pressure off of me as a clinician. Okay, because like if you are trying to control all your patients' behavior or control anybody's behavior, it is very frustrating. Like, anybody been in a relationship? You can't control your partner. And they can't control you for that matter. And anytime you try or they try, like folks butt heads because nobody wants to be controlled at the end of the day. And when I just talk to patients and kind of ask them questions and let them come up with their own solutions and kind of assist them, it becomes a more fulfilling experience as opposed to, you know, being this medical dictator, like, you're non-compliant, why aren't you doing this? Now I'm more of a teammate, okay? So if they're winning, I'm winning with them. If they're, you know, struggling, like, I'm also part of the struggle, and we have to figure out how to navigate this as a team.
Thank you for that. We're going to shift a little bit here. A couple questions, Dr. McDonald. Some interest in your study on microbiome. And a couple questions about any additional follow-up measurements after, like 6 months later after the initial study was presented, and done. I mean, in terms of like looking for sustainability of the impact?
Yeah, so it's a good question. So let me back up a little bit. The study, our cooking classes, we do 6-week cohorts. Everybody meets once a week. And for our microbiome and metabolome cohorts, we are checking, doing stool analysis before and after the cohort. Okay. So what we found was just by attending our classes, without, controlling everything that everyone ate, the gut microbiota changes in positive ways, okay? So one way the diversity in terms of the bacteria increases, and one sign of a healthy gut, quote unquote, is a gut that can harbor or support a wide variety of bacteria as opposed to a narrowed amount of bacteria based upon types. And then we've also looked at specific nutrients or metabolites within the gut. So one marker of fruit and vegetable consumption is short chain fatty acids, okay, specifically butyrate and acetate. So when people are consuming more fruits and vegetables, ideally, you should see their short-chain fatty acids increase. So without me relying on, food frequency, food 24-hour dietary recall and food frequency questionnaires, which, those are great, but the issue with those, there's still a little bit of recall bias, okay? So instead of just asking somebody like, well, what'd you eat yesterday? A lot of people don't know what they ate yesterday. And what they ate yesterday may not necessarily be representative of what they eat an entire week. So there's just a little bit of bias. And what we found was throughout our classes, short chain fatty acids just started to go up exponentially. And we also looked at sugar alcohols as a marker of ultra-processed food consumption. So people come in, their sugar alcohols are off the charts. They leave our classes, sugar alcohols start to go down. And it's very fascinating. And we are in the process of looking at the long term. So I just have a lot of data from at least 40 different people where we're looking, the short term after the 6 weeks pre and post, but now we're going back to look at the 6-month data. And hopefully with that, I plan to use it to get, further funding like NIH and stuff like that. But what I found was that the cooking classes do have a real impact. And it's an impact that is demonstrated in changing not only physiology, but also the microbial makeup of the bacteria within the gut, which again can have huge health implications. Okay, so for me as a gastroenterologist, I mean, this is what I do. So I see a lot of people who have gut issues, and a lot of those issues stem from a combination of different things, but trauma, the foods that we eat, and also the type of bacteria that we have in our gut. And that's all kind of interrelated. And we have, figured out a way to kind of tweak that. And now we're trying to figure out how to study that a little bit further.
Thank you for that. Chef Dan, we had a couple questions about how did you get the nerve to leave a steady job in DC and go work for free somewhere else?
Yeah, that's a great question. A lot of people were asking me that question, including my mother, who I needed. There was a time where when I was at Noma, she was so excited, and I was like, just remember that time when you thought I was an idiot for leaving my job before. I don't know. I'm not some like extraordinary person. I had like a gut feeling at a time where I still to this day was probably the best, because I started now it's like a struggle having a small business, and at that time it was a very good job and I was getting paid very well, and it was just so clear to me that didn't make me happy. And I like nice things, like don't get me wrong, like I'm not trying to make it seem like I don't like to have money and do things. I do, but it was so apparent to me in that moment that I was like, I have everything that I like. At that time, I was a young person. I started that job when I was like 24, 25, and I felt really good in a lot of ways. But in terms of career and purpose, I was like empty, if you will. And it took a lot of guts. At the time, I had a serious partner. I had a dog. I moved them to Copenhagen without a job. It was like a big thing. So Yeah, I think for me, it really, I've taken a lot of risks in my career. I didn't mention some other times. I mean, starting this company was a risk. In my personal life in general, I feel like I'm a very conservative person. You know, I follow the rules, this kind of thing. But with the career piece, I always just kind of felt like if I'm not happy, then I just got to make a choice, and I'm willing to take the risk because I think for me, work means a lot to me. I don't look at it as work. I never have. If I'm spending Monday through Friday or every day, 6 days a week, whatever, 10 hours a day doing it, it better be something that fulfills me. And you know, I don't work for the weekend, as the song says. You know, this is my life, so I'm always seeking for that, and I feel very fortunate that with what I do now, I have found that as well. But that's why I initially left the job here in DC. Yeah.
It sounds like you had the courage to like follow your passions.
You need to, yeah. I think it's slightly uncomfortable to talk about because I don't really consider myself like the most. I don't know. Like I don't take a lot of risks. Like I said, I'm not an adventurous. I don't go camping and like go out in the wilderness and like I was like pretty lame in a lot of ways, to be honest.
That's because it's going to storm, right?
Yeah, exactly. I was afraid of thunderstorms until I was 17, and I wouldn't even go outside if there was like, I'd be like, oh, it's a funnel cloud. It's like, it's not a funnel cloud like this. So, with my career path, I guess I could say that, yes, I was courageous.
Yeah, I bring it up because I think, you know, with culinary medicine or focus on nutrition, especially in today's climate, a little bit less so in today's climate, but in the past, it did take a lot of courage because nobody was really focusing on this. I mean, the healthcare system it's still trying to figure out how do you incorporate the role of food in disease management and disease prevention. And you know, for many of the people in this room, we are the early adopters. And whenever you're an early adopter, it takes courage to, you know, be able to kind of think outside the box. And also takes courage to, you know, potentially fail and make mistakes and learn as you go. I remember when I was a resident, I was at Northwestern, which is a, you know, pretty solid residency program. And I was going to my program director. I'm like, yeah, you know, I want to focus on nutrition. I may want to go to culinary school. Now, prior to all that, I was in the lab doing basic science research and, you know, sacrificing mice every day. Like what? If I don't get to heaven, it's because I killed a lot of mice. Like, that's why I stopped. I'm like, you know, we say sacrificing mice. This sounds very odd. Like, but that's a whole nother conversation. So I tell my program director, I'm like, yeah, I want to get out the lab. I'm tired of killing mice. Like, I want to focus on nutrition and cook. And I'm going to do a fellowship in nutrition, and I'm going to get trained as a chef. And she was just like, you are crazy. You are going to throw away your academic career. Like, you are not going to amount to anything. You're never going to be a gastroenterologist. And, you know, that same person is asking me to come back to work for her institution. And, you know, I've given grand rounds at the hospital. But it took courage to, you know, step out of my comfort zone career-wise and really pursue what I thought was valuable and what I thought was important. So I think your story it's very relevant to everybody in this room because it does take courage to figure out how do you navigate all this? How do you incorporate culinary medicine into your practices? When I started, I mean, I was just doing cooking classes in empty conference rooms in the hospital. Like there was no grant, there was no, you know, magic benefactor that gave me $1 million to set up everything. There was no teaching kitchens. Like I went to Home Depot, bought some, you know, bins. I went to one of the culinary restaurant depots that they have in Chicago and bought a bunch of burners. I used my own money, okay? So I'm like, well, you know, I'm a physician. I think if I spared $1,000, like, I'm not gonna end up homeless, you know? So I bought a lot of my equipment, and my wife was like, dude, you just spent $1,000 on knives and stuff. Like, what is wrong with you? And but I had a purpose, and I did it. And honestly, I found empty classrooms in the hospital and just put up some signs. And like, I didn't book any rooms. I didn't ask anybody's permission. It was all bootleg, you know. I was a certified food handler, so I had that. I had that covered. But I just started doing it. And I put up these signs, in internal medicine clinics and GI clinics. And, at first, 5, 6 people show up. It's like, okay. Next thing you know, it's like 30, 40 people in there. Next thing you know, my colleagues, they started seeing what I was doing, and folks were like, well, could we add you on a grant and you like do the nutrition education component? And at that time, I was a busy clinician. Like I didn't have protected time. I was like, 120% clinical. And someone gave me, 5% protected time to do a class, once out of the month or something like that. But it just snowballed. But it took the courage to kind of just start to some degree.
Yeah, I think that's a similar experience that a lot of us have is when we're trying to get our program going and started, a lot of naysayers, a lot of persons saying, no, we're not going to, what are you doing? You have a successful practice here. Why are you stepping away from that? Why are you jumping out in this arena or that? Or what are you doing? Or how does that help people? And so, yeah, we are trailblazers. We're early adopters. And I think to have the courage to hold fast to what you believe in and knowing what makes you happy and knowing that your patients will benefit, I think is really great advice and real important with that. Thank you both for that. Circling back around to some scientific things, food allergies. Chef Dan, tell us about your, how have you had to navigate that in the school environment? Is that significant, right, with all the different health issues that kids face?
Yeah, it's huge, and I talked about food safety a few times, and obviously that's kind of adjacent, food safety and allergies, but I'm neurotic about when it comes to preparing food and ensuring that people are safe when they eat that food. Obviously, I think that then you can talk about allergies, and my kind of feeling towards this predates going to, doing the work that I do now, and it's just, I think no matter who you're feeding, whether it's in a home, I was actually a gentleman here, I went into a Starbucks in DC this morning, and there was a gentleman, a homeless gentleman out front who asked for a milkshake, and I was like, I don't know if they have milkshakes here. And he's like, no, they have milkshakes. So I got him like a frappuccino because the woman said that's the closest thing to a milkshake. And I asked him, I went back out and I was like, can you have coffee? Like, can you have caffeine? And he's like, no, that's fine. But like, I think that's an attitude you take that no matter what you feed someone, you're always thinking about like, could it affect them in a negative way? And I think the idea that you can kill someone I've worked in restaurants that have had very severe things that have happened, and I've heard a lot of crazy stories. So I think in schools, what's difficult is a lot of the allergy information in terms of students who have allergies, that information is held by the nurses. In a lot of school districts, the nurses literally work for an outside organization and are contracted. We are an outside organization who are contracted. Sometimes it's difficult to get all the information that we need. Some school districts, for example, I don't know if this is the case now, I'm sure it is. We worked with New York City Public Schools 3 years ago. Now they have 1,800 schools, they feed 1 million kids a day. But their allergy, I remember this, we started working in a high school in the Bronx. 1,200 kids went to that school, and we got the allergies, and one kid had an allergy. So we're like, okay, what's going on here? And the way they take care of allergies is the only way you can get recognized as a student with an allergy is if you go through the full-blown like recognition of like a disability. So they basically encourage, the reason they do it is because nobody does it. So then they have no liability. So then they just, that's my 2 cents on it. It's not like anyone ever told me that, but I don't know why else you would do that. It's just an easy way to say, well, we don't have to worry about all the allergies are out there. And a year before starting there, a young child died at school, 4-year-old child. He went into anaphylaxis. He had severe allergy to dairy, and he ate a grilled cheese sandwich. He was 4 years old, because how do 4-year-olds know what's going to kill them and they're going to eat it? So allergies in schools are terrifying, and I honestly don't think that most school districts are in a place, and this is a problem because, we go into schools and it's like, okay, the food is very basic. And then now we want to introduce more foods. And it's very terrifying because you're like, well, these are different foods. Have these foods ever been served in this school? Probably not. And we're talking about basic stuff. I'm not talking about anything crazy. And we do stay away generally from, we're not going to serve shellfish. We don't serve nuts of any kind, except for the school districts we work in. There are school districts that still serve peanut butter, which we tell them it's funny because there's a lot of districts that have gone to a place. Most districts have, there's no more peanut butter and they just serve, an alternative nut butter like or seed butter like sun butter. But some still serve peanut butter because they're like, well, we don't have that many kids who are severely allergic. And it's like telling them like operationally something like peanut butter that's like so thick. And it's like, well, what's your process to ensure that this thing that you use to just put peanut butter on a piece of bread is actually clean? You put it through a dishwasher. Okay, so now, like, there's so many questions that need to be asked that nobody has the answers for. And that's just terrifying. So when it comes to allergies, I think it's just all about vigilance and explaining to people that they just need to, I mean, you can have a million safeguards in place, and there are. So like having signage that says, okay, these are 3 of the top allergens that are in this meal. The signage is there so students can see it. The best system I've seen, and a lot of school districts don't necessarily have this in place, is that they have like a POS system, like a point of service, like point of sale system, that when a child puts their number in, it alerts them immediately that they're allergic to this item. And then if the food's there, they can look at it and they can visually, determine if, but that also depends on them getting the information from parents and making sure that information is correct. There's so many places where that can go wrong. There's so many places, and I just don't feel like the systems that are in place are adequate and they're serious enough to really account for the severity and the amount of allergies that are, that students have.
Yeah, I agree with you. I mean, even from doing cooking classes and cooking demonstrations, it is always good to be aware of what foods people are most commonly allergic to. I'll give you a good story. Even if you're not cooking, so I was asked to speak to some junior high school students, and they wanted me to do a cooking demo, but I had procedures that day, and I'm like, I'm coming from like doing colonoscopies. I don't have time to set up like a demo. Like I have to come home, shower, bring, all my equipment in. Like it's a lot. But if you just want me to talk to some high school students, I can show up and talk to high school students. Junior high school students. So this was a nonprofit organization. They were like, oh, don't worry about it. We'll take care of the food demo. Like you just have to come in and talk. And I'm like, fine. So I show up after doing a day's worth of colonoscopies, and they're setting up the food demonstration. They're about to hand out the food just as I'm walking in. And they were making a peanut butter granola parfait. So they had yogurt, they had peanut butter in the bottom, they had granola with nuts. And I'm like, wait, hold on. Like, anybody in here allergic to nuts? And like 15 kids raised their hands. And I'm looking at this organization. I'm like, yo, you could have killed like 15 kids. Like, we're trying to do community outreach, and you're about to be a serial killer. Like, a serial killer with cereal. Like, and I'm like, it was like the Matrix. Like, I'm like, no. Like, I'm blocking the cereal and everything. And I'm sure they thought I was crazy. They're like, why are you doing this? But, food safety and food allergies it's something that we all should consider, okay? Because one thing that potentially could threaten your program is if everybody's getting sick. And I think you need to approach it with the same scrutiny that restaurants have. So it's, I do recommend that everybody gets licensed and certified as a food handler. You should have a basic concept of food allergies. And even with a lot of my demos, I'm not gonna lie, I carry an EpiPen. So I have this little kit that I have that has all my culinary equipment and everything, but I have at least one EpiPen. And I never, do shellfish, never do shrimp and stuff like, or never do any peanuts or anything like that, because these allergies are just so common. I don't even want to worry about it. Food safety wise, really just understand how infectious disease, foodborne illness is a big problem. And I'm a gastroenterologist, so I see people who are hospitalized when they have E. coli. I know what that looks like. And even from a little kid perspective, the number one cause of renal failure for kids is HUS. And that's from E. coli, from eating poorly cooked hamburgers. So it's one of the reasons why I don't really, for my cooking demos, I don't really cook, meat if I'm just doing a demonstration. If I'm in a kitchen, we have a little bit more options in the kitchen. But it's always good to, not only focus on food safety, but even also think about the medical legal aspects of what you're doing. So if you're starting a teaching kitchen, I'm in my teaching kitchen, like I said, is being built right now, but I have the hospital lawyers and like everybody going over stuff. Not for the sake of being defensive, but like I just want to make sure we're doing everything as responsibly as possible.
I think that's one of the first questions we have as we start each of our classes is, as we go over the ingredients for the class or the recipes, and we ask straight out, anybody have an allergy or sensitivity to this particular item or food? So we make sure that they either don't eat it or they don't participate in making it or both in terms of that. So excellent advice from both of you. So Dr. McDonald, a couple questions for you about, so when you have the ask, and the patient says, no, I don't want to talk about food. Or you have the ask and the patient says, no, I don't want to talk about food, but I want one of them new shots that helps me lose weight.
Ooh.
That's got to be a hot topic.
It is a hot topic, yeah.
Another hot topic.
Like, let me roll up my sleeves here. Okay. So a lot of people are interested in semaglutides. I don't want to use the trade names because we're at a conference, so I want to respect the CME rules and everything. So these are GLP-1 medications that are injectable that can be very effective for weight loss. So I do have patients who don't necessarily want to make lifestyle change, and they just want the medications, okay? So for that population, one, I look at these medications as tools, okay? So I've seen, various social media influencers take hard stances against some of the medications. I take more of a realistic stance in the sense that, one, I value lifestyle change. So I value the role of food. I value the role of physical activity, and then also mental health and sleep and, all the different things that can correspond or affect our behavior. Like I value all of that, and I think that is the foundation, okay? Now, for some people, that foundation may or may not be enough, and there are tools that we might have to add to it, okay? And there's a variety of reasons why it might not be enough. Someone may have mobility limitations, and they can't exercise because their knees hurt, or they had a stroke and they can't move, or, other people may have other structural issues where it's just hard to, eat the diet they want to eat because there's a lot of different obstacles. So for people who just want the medications, I always go back to the clinical trials, okay? And so the clinical trials for these medications, people were not only taking the medication by themselves, people in the trial, they all did at least 150 minutes per week of exercise, and they had to decrease their caloric intake by 500 calories based upon what they would normally eat per day. So when people are just like, look, man, I don't want to change my diet. I don't even want to talk to your dietitian. Like, just give me the meds. And I say, well, what is your goal? And again, it goes back to motivational interviewing, okay? So for some people, I can't force them to exercise. I can't force them to eat healthy, but I can provide information, and I can provide information that is in line with their goals. And I'm like, if your goal is to get the most out of this medication, or if your goal is to not, rely on this medication forever, here are some things that may help you actually not need the medication. And one is the foundation is going to be exercise, and most importantly, really food. Like I love exercise, but the problem with exercise, it's actually hard to burn off a lot of calories. Mm-hmm. You can run like 3 miles and like you burned off 2 cans of pop, if that, if that. And for a lot of folks, especially as we age, like to get the degree of exercise that you need to really lose a whole lot of weight without any dietary change, that may not necessarily be the most effective strategy. So I really, have to help people understand that, burning these calories is harder than just eating less, which eating less is hard in America. Like it is hard. Food is delicious. I get it. But ultimately for these patients, there's never been anyone that I'm just not going to prescribe you the medication because you won't engage in lifestyle change, I will still prescribe it, but have them come back and continue to ask, like, so what are you doing for physical activity? Like, hey, remember what I said? The medication by itself may not necessarily be the most effective. Like, hey, what are your thoughts on coming off the medication? And that constant nudging is enough. So, in the spirit of motivational interviewing, you kind of roll with resistance to some degree.
I agree. I agree with that approach completely in terms of that. Being a multidisciplinary conference, I wanted to get both of your thoughts about how you incorporate our dietitian partners in terms of your work, both with your clinics in culinary medicine for you, and then also for Dan for your work in terms of as you go into a school, do you bring in some dietitians with you, or do you have some that you work with you in your company?
Yeah, I mean, what I will say is when I first started the company, I was like, oh, we need to get some dietitians. But then you realize that, I mean, in the school, the guidelines are set. Like, we're working within guidelines that are set. And I'll be honest, there are a lot of folks that are trying to like undercut the guidelines, meaning, this is the limit on sodium. We're going to actually make it less. You kind of shoot yourself in the foot to a certain extent because it's already very difficult to work within the guidelines and prepare food that's delicious that kids are going to enjoy consistently. So we actually have two people on our team that are dietitians. We don't really use them as dietitians. What I will say in some of the other spaces we're working now, senior center space and the prison space, the parameters are more open and they are kind of determined by folks who are of that background. So I think it's very useful. I've also, and this is just my personal experience, I think it would be great for folks with that background to be more interested in the work of feeding people. I don't know what the distinction is. I don't know if it's like clinical dietetics versus working in food, but so many of the folks that we meet don't seem to be that I've met don't seem to be super interested in just like food and feeding people and what does that mean. Most of the people that I've met who are registered dietitians are food service directors. That's the job that they've taken, and quite frankly, in our space of school food, the food service there's a big transitioning happening right now where a lot of folks who are food service directors are retiring, and nobody's taking those jobs. And talk about a job that you could take to be super impactful. Like there's so many. If you look right now, there's thousands of food service director jobs out there, all of which pay over $100,000 a year. Some pay $150,000 a year. And you can be in charge of a school food service program feeding tens of thousands of kids and like really making impact on their life. But I think so for me, I know that's not necessarily answering your question, but we're not really involved much, the folks that we do work. And I will say that those registered dietitians who are food service directors, I don't believe rely on their skill set as registered dietitians because they're all using nutritional software to ensure compliance. So you're really just working within the guidelines all the time versus saying, okay, because you don't have the freedom to work outside of that. I think other institutional food service settings, you do have more freedom. So I think having somebody with that skill set who you can work with to say, hey, let's adjust this or let's change this. But unfortunately, I think I think there has to be nutritional guidelines. But I will say the way they're made, and for example, something that was just recently passed at a federal level in 3 years, the sodium level will go down further in school food, making it that much more difficult to make food that anyone in this room would enjoy eating, let alone kids. You would be like, this doesn't taste good to me because there's not enough salt here. And when I'm talking about sodium, I'm really talking about just using salt to season food, obviously not the sodium that's in processed foods as preservatives. It just makes it very prohibitive. So, but if there were not guidelines, then I think we'd be in a much worse place. So I do agree with that. But I'd love to have more conversations and kind of interaction with dietitians. We don't, to be honest.
So dietitians play an amazing role when it comes to culinary medicine and food as medicine interventions. And I use dietitians in a variety of different contexts. One, clinically, I help run our nutrition support team. So we do our TPN and like the tube feeding and our nutrition and all that stuff. So I utilize dietitians in that regard. In our weight management clinic, I have 2 dietitians who work with me. And the way we use all of our dietitians, I almost had to make a case to the hospital as to why the dietitians are valuable, which is crazy that you have to do this. I mean, like I shouldn't have to, tell the hospital why dietitians are valuable, but this is the world we live in. So in my clinic, a lot of my patients, their insurance will not cover a dietitian visit. Okay, so if you don't have diabetes and you don't have chronic kidney disease, it might be hard to actually get a dietitian coverage to some degree. So I made the argument that if they just allow me to bill at a higher level, and that higher level in of itself will cover the dietitian's salary. And like the people in the hospital, they kind of worked out the math and they found that I was correct. So what we do is I'll see a patient for a half hour, go to the next patient, the dietitian is going to see him for a half hour, and we do everything staggered. So all my patients have access to dietitians, even if they have Medicaid. So if you have Medicaid, and Medicaid definitely won't cover a lot of dietitian visits, it's kind of roped into the cost overall of just coming to see me. And the hospital has been very supportive with that. And so I do feel blessed to be at a hospital that can eat some of those costs. But I'm at the University of Chicago. I mean, we're a big institution, but our patient mix is still, very Medicaid, Medicare heavy. So it's not like we're making tons and tons and tons of money, but they're still very supportive. As far as classes within the hospital, so we have group visits, and some of those group visits are culinary medicine. So one, I can bill a level 3 for a group visit. So I can have, 15 people come in for a 1-hour class, and everyone gets billed a level 3. And we'll do classes with the dietitian. So it started off as almost kind of a nutrition education class where I'm talking about, what are calories? How do you read a food label? What is protein? What are all the different macronutrients? So how do you shop? And I created a curriculum, co-created a curriculum with one of our dietitians. But we do the class together. And then eventually got to the point where I got to bring in some burners and show some recipes. But I do that in combination with a dietitian. And the curricular development, having a dietitian involved in curriculum development is key, okay? Because at the end of the day, for me as a physician, like I actually wasn't trained to talk to people about food. Like as crazy as that sounds, like that was not a part of my training. And, I probably trained myself through experience and, having these conversations. But as a medical student at a top-notch medical school, no one told me, like, this is how you talk to people about food, or this is how you create curriculums that are geared towards behavior change. So with a lot of our dietitians, they do have that training. They do have some of that knowledge base and some of that skill set. So I use them a lot when it comes to curriculum development. And then with our cooking classes in the community, anytime I get a grant or anything like that, I always try to set aside some money for a dietitian as opposed to just expecting people to kind of volunteer their time and talk to the folks in the community. Like I actually want people to be able to be compensated.
Thank you both for that. I'm going to now hit you with a 30-second elevator pitch. You each get 30 seconds. What role do you see chefs playing in culinary medicine going forward? 30 seconds.
Thanks. That's good. That's great. Yeah. I mean, I can't say anything in 30 seconds. I don't know how to tell you that. What I will say, I mean, honestly, to me, it's very basic. Chefs are people who are trained to cook, and more importantly, they are trained to train other people how to cook. So anytime anything involves the preparation of food, a chef has a place there. And I think that's just a pretty basic concept that maybe that's because I'm a chef, but it's kind of a no-brainer.
Dr. McDonald, you have to top that now.
I agree. So chefs know how to make food taste good, and they know how to make it fast, and they know how to do it in an organized fashion. And I think that organization aspect is really key when it comes to cooking. And I think for some people, one obstacle is, cooking in a way that's organized and efficient is an obstacle. And I think chefs can help address that.
Absolutely. Thank you both for that. Thank you very much for that. Just a couple announcements. The